If you've ever had a child on your table who couldn't settle, or an older patient whose pain just never seems to resolve no matter what you do, this episode is going to give you a framework for understanding why. Because trauma doesn't just affect the person who experienced it in that moment, it changes the body, sometimes permanently. And it does that differently depending on when in life it happened. Hey there, I'm Jamie Johnston, and you're stepping into a new era of thriving as a massage therapist. We're embracing who you are, pursuing what you love, and confidently shaping your practice. We'll challenge industry norms, spark change, and discuss what truly matters. Things like mental health, evidence-based practice, and some topics we've long avoided. Let's create better outcomes for our patients and happier, more fulfilling practices together. Welcome to the New Generation Massage Therapist Podcast. Welcome back to the New Generation Massage Therapist Podcast. I'm Jamie Johnston, and today we're going into episode 2 of our series on trauma and the nervous system. And this one is called Trauma Across the Lifespan. Last episode, we talked about what trauma actually does to the nervous system, how the amygdala can become like a smoke alarm that gets stuck on high alert, and how that shows up in the patient sitting on your table. If you haven't listened to that one yet, I'd go back and start there. It'll make everything we talk about today land a lot better. Today, we're going a step further, because trauma doesn't affect a 7-year-old the same way it affects a 35-year-old or a 70-year-old. And as massage therapists, we can work across the entire lifespan. So I want to walk you through what the research tells us about how trauma lands differently at each stage of life and what that means for the people on your table. So let's start at the beginning, childhood. Early trauma, and I mean significant, chronic, or repeated trauma during childhood, doesn't just affect a child emotionally. It can physically alter a child's developing brain and actually change their genes. So I want to sit with that for a second because I think it's one of the most important things we can understand as therapists. We're not talking about a child who had a rough experience and needs time to process it. We're talking about structural and neurological changes to a developing brain. Changes that can follow a child into adulthood and right onto your treatment table decades later. Here's how it works. When a child experiences severe trauma, it triggers what are called epigenetic changes. Now, epigenetics are a fascinating area of research, and the simplest way I can explain it is to think of your genes like a series of light switches in your body. These switches can be turned on or off based on your life experiences. They don't change the gene itself, but they can change whether or not that gene is expressed or gets expressed. What childhood trauma does is essentially take one of those switches into the off position. The specific gene that's affected is called NR3C1, and this gene is responsible for building the receptors that grab cortisol. So you might remember from episode 1 that cortisol is one of your stress hormones. When cortisol floods your system, you need enough receptors to catch it, process it, and signal the brain that it can calm down now. But if NR3C1 is switched off, you don't build enough of those receptors. And without enough receptors to catch the cortisol and tell the brain the threat is over, the stress response just keeps running. The alarm never gets the signal to stop. And what this creates long term is a state of chronic hypervigilance. The child's nervous system stays on high alert, and their prefrontal cortex, the part of the brain responsible for rational thought and emotional regulation, actually develops asymmetrically. When this happens, we see functional and structural differences between the left and right sides of the prefrontal cortex in children who've experienced significant early trauma. And here's why this matters so much for us clinically. Because these children grow up. Because their HPA axis, that's the hypothalamic pituitary adrenal axis, the system that regulates their stress response, is permanently altered. These adults are highly vulnerable to developing things like central sensitization and severe persistent pain conditions later on in their life. That persistent pain patient in their 30s or 40s who has never responded well to treatment, the one whose pain seems disproportionate, widespread, and resistant to everything you try, there's a real possibility that their nervous system was rewired during childhood and that their pain is not a mechanical problem, it's a biological one that started decades ago. Now, I want to take a brief detour here because some of you do treat children. And occasionally, a parent will bring a child in for treatment without fully understanding what's happening for that child emotionally or neurologically. Now, I'm not suggesting we become therapists or counselors. That's absolutely not our scope, although you could go to school and become that if you wanted to. But part of being a trauma-informed massage therapist is knowing when to gently point a family toward the right support. So here are some red flags that the research points to, things that a parent might share with you or things you might observe that suggest a child may need professional psychological support beyond what we can offer. First is extended periods of depression, excessive grief, or purposeful withdrawal from friends and family. Second is persistent anxiety about a specific event, or conversely, complete avoidance and denial of it like it never happened. Third is behavioral shifts, things like destructive outbursts, acting younger than their age, or a sudden decline in school performance. And fourth, some physical signs, things like persistent sleep problems, changes in appetite, or ongoing physical complaints that don't have a clear medical explanation. If a parent mentions any of these things, you're doing that family a genuine service by saying it might be worth speaking to someone who specializes in this. A counselor or psychologist who works with children could be really valuable here. That's not overstepping, that's being a good clinician. And if you do have a child on your table, the research is very clear on what helps them feel safe. Be emotionally and physically present. Be a good listener. Give them choices where you can, even small ones like which arm to start on, because choice restores a sense of control that trauma takes away. Respond calmly to their behavior instead of reacting to it, and keep things predictable. Consistent routines in a calm environment are genuinely therapeutic for a dysregulated nervous system. And one more thing, and this is for the parents in the room too. You cannot pour from an empty cup. Your own well-being directly impacts your ability to support a child through trauma. That's not platitude, it's neuroscience. Okay, let's move into adulthood, because this is where most of your caseload probably sits. I've done a full presentation on allostatic load inside my MTDC community before, and I've done a podcast on it. So some of you will have some familiarity with this concept. But I want to go a little deeper here because I think it's one of the most clinically useful frameworks we have for understanding why our complex adult patients present the way they do. Allostatic load is essentially the long-term wear and tear on the body from chronic stress. Think of it like a bank account, except instead of money, you're dealing with psychological stress. Every time your nervous system activates the stress response, it's writing a check. And as long as you're recovering well between stressors, you can manage the balance. But when the stress is chronic, checks keep getting written and the recovery never happens. So the account goes into overdraft. And that overdraft shows up in the body in very real, measurable ways. Here's what it looks like biochemically. The continuous flood of cortisol and epinephrine that comes from chronic stress drives systemic inflammation throughout the body. It suppresses immune function, which is why chronically stressed people get sick more often and heal more slowly. And it puts sustained pressure on the cardiovascular system, increasing the risk of hypertension and heart disease. But for us, the most important thing to understand is what this does to pain. Adult clients with unresolved trauma often present with severe, widespread, and mutually maintaining persistent pain. Now, that phrase, mutually maintaining, is key. What it means is that their pain and their psychological stress are locked in a feedback loop, where each one continuously amplifies the other. The pain drives stress, the stress drives more pain. And breaking that cycle with manual therapy alone is genuinely very difficult because the problem isn't just in the tissue. It's biochemical, it's systemic. This is also why movement matters so much. And I'll be talking more about this when we get to the course, but the research is really clear that graded movement and active recovery can interrupt that feedback loop in ways that passive treatment simply can't. Now, allostatic load doesn't just accumulate during acute trauma. It builds slowly over years of unresolved stress. A patient who appears to be functioning well on the surface might be carrying a physiological debt that's been building for a decade. And then one day, sometimes triggered by what seems like just a minor injury or illness, the system tips. And suddenly, they're presenting with widespread pain, fatigue, sleep disruption, and a stress response that seems completely out of proportion to what you're seeing on your assessment. That's not a complex patient. That's an overdrawn account. And then there's what happens as we age, because this is where the story gets even more important for those of you who treat older adults. As we move into our later years, our endocrine system changes. And one of the key shifts is that older adults experience a sustained elevation in baseline cortisol, not just during stress, but all the time. Their cortisol is running higher than it was when they were younger, even when it was a calm day. And that matters enormously because cortisol at chronically elevated levels is physically toxic to the brain. Specifically, it damages the hippocampus. The hippocampus is your brain's memory and learning center. It's also one of the primary structures involved in regulating the stress response. So, when cortisol damages the hippocampus, you get a double hit. You lose memory and cognitive function, and you also lose one of the brain's key mechanisms for calming itself down. This is why cognitive decline and chronic stress are so tightly linked in older adults. It's not just correlation, there's a direct biological mechanism. Chronically elevated cortisol physically degrades the tissue responsible for memory and recovery. And for some older adults, the risk is even higher. There's a specific genetic variant called APOE4 that makes the aging brain significantly more vulnerable to the damaging effects of chronic stress. Think of it as an amplifier. It takes the toxic effects of elevated cortisol and turns the volume up. Individuals carrying at least one copy of this gene experience a much steeper decline in memory and cognitive function under stress, and their risk of developing Alzheimer's disease is meaningfully higher. Now, I'm not sharing this so you can start diagnosing your older patients with genetic risk factors. That's completely out of our scope. But I am sharing it because it changes how we think about what's appropriate on your treatment table. Your geriatric patients simply don't have the same biological bounce back. Their nervous systems have a significantly reduced capacity to recover from both physical and psychological stressors. What a 35-year-old can process and recover from in 24 hours might take a 70-year-old a week or longer. An environment that feels mildly stimulating to you might be genuinely overwhelming to their nervous system. This means our clinical environment matters even more with older adults. The pace of treatment, the level of sensory input in the room, the predictability of the session. These aren't just comfort preferences for some of your older patients. They're genuine clinical considerations. So let's bring this together. Trauma doesn't stay in the past. It lives in the body, and it lives differently depending on when it was experienced and how long it's been carried. In childhood, it can physically rewire the developing brain and alter gene expression in ways that create vulnerability to persistent pain and dysregulation for decades. In adulthood, it accumulates as allostatic load, driving systemic inflammation, immune suppression, and a pain stress feedback loop that passive treatment alone struggles to break. And in older adults, an already elevated cortisol baseline combines with reduced hippocampal resilience to create a nervous system that simply cannot recover the way it once could. Every one of these patients is on your table, and now you have a framework for understanding what's actually happening beneath the surface. Next episode, we're going to talk about what trauma-informed care actually looks like in practice, not just as a philosophy, but as a set of concrete clinical decisions you can make in every session. Because understanding trauma is one thing, knowing how to respond to it is something else entirely. If this episode was useful to you, share it with a colleague who you think needs to hear it. And if you want to go deeper, I've put together a focused mini course called From Feared to Functional that takes some of the things we're covering in this series and gives you a clear clinical framework for understanding why your persistent pain patients stay stuck and what to actually do about it. It covers the fear avoidance cycle, the biopsychosocial model, how to meet your patients where they are, and how to start building real resilience instead of dependency. All for $37. The link is in the show notes. I'll see you next week.